All right, here we go. Morning, everybody. Happy Darwin Day. Welcome to Grand Rounds. Please join me in welcoming our own Dr. Eva Zinoviev today. She's originally from Albany, New York, completed her undergraduate degree at the University of Pennsylvania and her medical degree at Wake Forest. After her intern year at Cone Health System, she developed a strong interest in movement disorders, particularly Parkinson's related foot dystonia. Additionally, Dr. Zinoviev plans to apply for a fellowship in brain injury this year. Outside of medicine, she's a happily retired D1 collegiate athlete and now tries to stay active through hiking and running with her Army husband. Let's give a warm welcome to Dr. Zinoviev.
Good morning. Thank you for joining me virtually for this presentation. For those of you who have not met me, I'm a PGY3 resident, and I will be presenting on Parkinson's disease for the PM&R provider and rehabilitation for Parkinson's disease. Let me see if it'll, there we go. So we're going to do a brief review of Parkinson's disease epidemiology and pathophysiology. I promise one slide per. Then we're going to talk more about clinical features and physical exam for Parkinson's disease. I think this is important for PM&R providers, especially for our inpatient rehab providers who see Parkinson's disease patients come through for rehab, and also some of our patients who do not have a diagnosis of Parkinson's, but they're working with their physical therapists and they're coming to us with concerns that there might be some signs of Parkinsonism on exam. Then we'll talk briefly about pharmacological and surgical treatments for Parkinson's. I think these are useful to know, especially for our inpatient providers who might try a trial of Sinemet for patients who are displaying new features of Parkinsonism. And then we'll discuss some rehab modalities for Parkinson's disease and review some of the studies that support the use of some of these rehab modalities. Disclosures, I have no disclosures. Epidemiology, Parkinson's disease is an age-related neurodegenerative disease. It is the second most common age-related neurodegenerative disease after Alzheimer's. And there's an estimated 1 million people in the US that have Parkinson's disease, which is more than the population of MS, myasthenia gravis, muscular dystrophy combined. Parkinson's disease has a male predominance and is more common in white and non-Hispanic population. For pathophysiology, I've limited just to some visuals for the high-yield information. So on the left here, we see that there's a series of factors, including aging and environmental factors, and also to a small degree, some genetic mutations, which in the literature is anywhere between 5 and 20% of patients who then go on to cause these misfold proteins, these aggregated alpha-synuclein, also known as Lewy bodies, which cause apoptosis of the dopaminergic neuronal cells in the substantia nigra of the basal ganglia, which causes degeneration of the dopaminergic pathway in the extrapyramidal tracts, which control more complex body movements and result in some of the motor manifestations that we see. All right, so the clinical features of Parkinson's, the 4 cardinal features we can remember with the mnemonic trap. We'll talk about each of these. First, we have tremor. So tremor are these rhythmic movements that occur around a limb. When evaluating tremor as a medical student, I was never really sure how would I describe tremor on physical exam. What would I write? If I saw something that looked like rest tremor, would I just write rest tremor ? And then as I was in my movement disorders outpatient clinic as a medical student, I was taught this kind of way to evaluate different kinds of movement disorders, which I really liked and I found very helpful. So the way I was taught was that first you look for anatomical location. You see, is the tremor occurring just in the hand, in the whole arm? Does it include any other parts of the body, like the head or the face? Or is the tremor present in multiple locations? Does it seem like it's just unilateral, just the arm and the leg on one side versus bilateral? Or is one side more affected than the other? Then we also look at rhythm. Is it a regular rhythm like what we see in Parkinson's? Or is it irregular like what we can see in functional movement disorders? Is there a large amplitude or a small amplitude to the movement? And is the movement fast or slow? And then in a uniplanar or biplanar direction? And I find that being able to break it down like this is really helpful in patients who have a movement that doesn't quite fit perfectly with like a rest tremor or our classic central tremor. And also for patients who have multiple types of movements going on at the same time. And I really like this article, Approach to Tremor Patient, which discusses a very similar process to this one. They also included this nice chart, which can show that once you've kind of identified frequency, amplitude, parts of the body that are involved, you can kind of then further divide and see what kind of tremor this then fits with. This is a very simplified way to think about classifying tremors, just to keep in mind as you're looking at a tremor and trying to decide, is it a rest tremor or does it look like a different kind of tremor? So I like to divide it into rest tremor and action tremor. So rest tremor meaning that the body limb is fully supported by gravity. There's no voluntary muscle activity going on, whereas in an action tremor, the limb is supported against gravity by voluntary muscle action. And so your action tremor or some of these other very common types of tremor, like a central tremor, your intention tremor, also called your cerebellar tremor, postural tremor. So for our Parkinson's tremor, as we know, it's the most common cause of a rest tremor. There's a very regular rhythm. That 4 to 6 hertz is the classic that we have to memorize for medical school boards. Usually a unilateral onset, can become bilateral as the disease progresses, can involve both the upper and lower extremities, classically involves the distal upper extremity initially. You can also see that pill rolling tremor, which is specifically when the tremor involves the thumb and the forefinger, as though the person is rolling something between the two fingers. But it can also include like wrist extension, supination, pronation, or a combination of these. The tremor can also then later progress to involve things like the lips, chin, jaw, and legs. You can also see a rest tremor and then an associated postural kinetic tremor. If it's the same frequency, it's termed this reemergent tremor. And then you can also see rest tremor with more of a like a central tremor-like features as well. And then, like Dr. Hyland alluded to, you can see dystonias in patients with Parkinson's disease. And I think what he was referring to is that in medical school, I specifically did some research in Parkinson's related foot dystonia, and we used Botox for these patients that were medically refractory to pharmacological treatment. For the physical exam, it's very simple. We start with our examination for rest tremor, and we have the patient rest their hands in their lap, trying to relax. Sometimes it's helpful to ask the patient to perform a cognitive task, like naming the months backwards, which can distract the patient and sometimes help bring out that tremor. Next is our exam for postural tremor. The patient's asked to hold the hands out in front of them, and we assess for the patient as they're holding their hands up against gravity with no kinetic movement, seeing if there is a postural tremor present. And then lastly is our examination of looking for an action tremor or intention tremor, where you have the patient do a voluntary kinetic action such as finger to nose, or the patient standing in a T and then bringing the hands in towards the mouth. The second cardinal feature, rigidity. Unlike spasticity, rigidity is not velocity-dependent resistance to movement. For physical exam, we test passive range of motion. And then in medical school, we're taught these two terms, lead pipe rigidity, cogwheel rigidity. Are they the same thing? Are they different? So lead pipe rigidity is smooth, consistent resistance to movement through the full range of motion, whereas cogwheel rigidity is resistance that's more jerky or ratchet-like. And it's the same underlying rigidity, just when you are testing for cogwheel rigidity, it's in a limb that has the tremor underlying. And so, for example, you might see cogwheel rigidity in the hands and lead pipe rigidity in the shoulders, but overall, this is the same rigidity. What are other clinical manifestations of rigidity? I think we often forget to identify that these are related. But when patients report difficulty getting up from a chair or starting a gait or freezing gait, that's also related to underlying rigidity, as is reduced arm swing. Also, this masked facies, which is also related to bradykinesia. And then musculoskeletal pain, I think, is often forgotten about. Parkinson's patients have a higher incidence of adhesive capsulitis, and then also some other kinds of more common shoulder pathologies, such as degenerative arthritis and bursitis and supraspinatus tendinitis. Our third cardinal symptom is bradykinesia. So bradykinesia is the slowness of movements with progressive loss of amplitude, speed, or changes in rhythm. And progressive is the important term here. So what we're really looking for is decrement in amplitude and speed. So as, for example, if the patient is doing finger taps, the finger taps will get smaller and smaller and slower. And then you'll also note often a loss of rhythm. So the patient will lose their regular rhythm with halts and hesitations. And then this is important to differentiate. So there's other movement disorders like PSP or essential tremor where you can see bradykinesia, but it doesn't have this classic decrement like we see in Parkinson's disease. For the physical exam, we do our finger taps. You can also have the patient pronate and supinate the forearm as if opening a doorknob. You can also do heel stomps, heel taps. And then it's useful to perform the finger taps with the patient so that you act as the normal comparison so that you can compare your ability to tap your fingers, your speed, your amplitude with the patient's. What are other clinical manifestations of bradykinesia? So micrographia, where the patient will have small handwriting, that can be a manifestation of bradykinesia. The shuffling gait with the small steps. In general, Parkinson's patients take these micro steps. Dragging the leg on the more affected side. Masked facies, also called hypomimia and reduced blink rate. Hypophonia and dysphagia. All right, and then the fourth cardinal feature of Parkinson's is one that I often forget about, posture and balance. And I really like this article from The Lancet, which talked about different kinds of postural deformities in Parkinson's disease, which we'll talk about briefly. So features of Parkinson's posture, they tend to have this stooped posture. They tend to have a narrow base of support, and they tend to have this, because of the stooped posture and because they're moving their feet so slowly, they tend to have this forward falling or forward center of gravity. For which they then try to compensate as they're falling forward. They feel the sense that they need to then move their feet very quickly to try to catch up and bring their feet back under them. And so that's called fenestration, when the patient has this image where the top of the body is falling forward, and then they very quickly try to shuffle their feet in small steps to try to catch up. Axial deformities, which we'll take a look at in a second, and then in general, poor balance. And this is all thought to be due to underlying muscle rigidity, axial dystonias, like a generalized myopathy, and then loss of proprioception. This is that fenestration. So you see the patient with a stooped posture, forward center of gravity, and then taking small, quick steps to try to bring those feet back underneath him. These are the axial deformities. So camptocormia is that forward flexion at the hips. There's an arbitrary number that this is about 45 degrees or greater is considered camptocormia. And then anticollis is this forward flexion at the neck, and Pisa syndrome, this lateral flexion at the hips. And so for these three, camptocormia, Pisa syndrome, and anticollis, these aren't fixed flexures. Or fixed structural defects. The patient can, if asked to lie down flat, can usually go all the way straight unless there's been some muscle contractures due to prolonged immobility. and then also scoliosis. For the non-motor symptoms, these are often forgotten about. These symptoms can often contribute greatly to quality of life. They often contribute to the decision-making to place the patient in a nursing home setting. And they often also progress like the motor symptoms do as Parkinson's disease progresses. And so these are also important to assess for in our patients. So for our neuropsychiatric symptoms, mood disorders, hallucinations, cognitive changes. So for cognitive changes, you can get Parkinson's disease with mild cognitive impairment, Parkinson's disease with dementia, where the cognitive symptoms develop at least a year after developing some of our other classic Parkinson's manifestations. And then for Lewy body dementia, to differentiate the two, for Lewy body dementia, the cognitive symptoms occur before or within a year of Parkinson's disease symptoms. And then in general, it's thought that these occur more on a spectrum, which is called the alpha-synucleinopathy spectrum. Autonomic dysfunction, orthostatic hypotension is the big one that can become specifically problematic in an IPR setting when doing exercise and therapies. Dysphagia can be severe to the point where patients are requiring PEG. Can someone turn off their volume? Because I'm hearing an echo. Hello? Awesome, thank you. Sleep disorders, another thing that we don't think about as often, but can become disruptive, particularly in an IPR setting. REM sleep disorder is a big one where these symptoms can start to occur before the patient starts to recognize any motor manifestations and could be important to ask in a patient who you think might have some features of Parkinsonism. And then Parkinson's disease medication can contribute to these sleep disorders, as can underlying mood disorders like anxiety and depression. The sensory disturbances I often forget about. Hyposmia, or the decreased sense of smell, is another one that can occur before, even several years before Parkinson's disease, like clinical manifestations, like the motor manifestations can become apparent. It can be another good question to ask. And then also, when I was at PADREC and they had these multidisciplinary visits for the patients, I was struck by how many of the patients reported visual difficulties with visual tracking and perception. And they had a vision specialist there and I think that was great. To be able to address that, because I think in a regular movement disorders outpatient clinic visit, it's really difficult to touch upon all these different manifestations of Parkinson's disease. So sometimes we miss things. These are is a more comprehensive list of some of the eye dysfunctions that can occur in Parkinson's. How do we diagnose Parkinson's? Just briefly, there's different scales we can use to identify symptoms of Parkinson's. Part of the UPDRS is a survey that the patient and the caregiver fill out, and then the other part is the part that the movement disorder specialist will fill out. Do we use diagnostic imaging? Not as often as one might think. You can use MRI or CT to rule out specific clinical pathology if it's also on the differential and you're not quite sure. So if you want to rule out stroke, like a vascular Parkinsonism or other forms of dementia. The DAT scan I have seen ordered infrequently, and when it has been ordered to differentiate between different movement disorders, so like essential tremor and Parkinson's, when there seems to be a lot of overlap. And then here is a DAT scan dope uptake. You can see on the left the healthy control. They have a more comma-shaped shape here, whereas in the advanced Parkinson's, you look more for that period-shaped image. What about lab testing? I included this. This is just something I learned at the symposium. Thought it was pretty interesting. We have this skin test available at VCU. It looks for alpha-synuclein proteins. It's a punch biopsy. The only thing with this is that it can't differentiate between the different kinds of alpha synucleinopathies, so Parkinson's, MSA, Lewy body dementia, pure autonomic failure. It wouldn't be able to tell you specifically that it's Parkinson's. There's also a CSF test, but I'm not sure if we have that at VCU. The Movement Disorder Society also has a series of diagnostic criteria for Parkinson's. It is a clinical diagnosis. They have a series of checkboxes that can give you an idea if you have established Parkinson's versus clinically likely Parkinson's, or if there are red flags and other symptoms that would suggest it's something other than Parkinson's. I think if we are in an inpatient role or an outpatient role, where we have patients and we're wondering if this is Parkinson's, it's good to know what the Parkinson's disease mimics might be to see if we can rule that out first. So Swedes is rare, but some patients have symptoms of Parkinsonism, but then if they get a DAT scan, they don't have any evidence of true dopaminergic deficits or true Parkinson's. Some of these Parkinson's-like symptoms are a little bit different. For example, they don't have that true decrement with bradykinesia. And then also our Parkinsonian syndromes like MSA, PSP, CVD. Vascular Parkinsonism is one that I've seen. They usually have a more symmetric onset of symptoms instead of unilateral. They also tend to have upper motor neuron signs. And then these patients are typically unresponsive to levodopa. Anemia and hypothyroidism can both kind of mimic that slowness and fatigue that can be seen in Parkinsonism and are pretty easy to rule out with lab testing. Drug-induced Parkinsonism are dopaminergic blocking medications in antipsychotics, and then Reglan is a big one that I've seen. And then there's also medications that can cause specifically the tremor that can look like rest tremor. So it's important to take a look at those medications too. Pharmacologic treatment, I know is not everyone's favorite. We will talk specifically about clinical pearls for the IPR provider. So levodopa, carbidopa is still the gold standard. These are some of the newer names on the market. We'll talk a little bit more about Duopa and Inbrija in a second. Just as a reminder, the carbidopa helps prevent the peripheral breakdown of dopamine so that more of the levodopa can go through the blood-brain barrier and enter centrally. Usually we see carbidopa and levodopa in a 1:4 ratio, and that's why we tend to see the Sinemet 25, 100 milligram dosage. And then this is usually the initial dosing that you would start a patient on. If you're doing like a Sinemet trial, you'd probably do Sinemet 25 to 100 TID to see if they respond to it. Levodopa side effects to consider if you're starting the medication for a patient. Nausea, vomiting is a big one, especially in the beginning. Some of these symptoms can also overlap with symptoms of Parkinson's disease in general, so lowered blood pressure and confusion. And then for patients that are on high doses of levodopa, the one to look for is dyskinesias. If you're going to start a patient on Sinemet, it's just, I thought this was really useful to know. I learned this at that symposium that I went to last year. It has a yellow dye in it that the rest of the formulations don't have. And if you start it and patients get this maculopapular rash that can be itchy, it can be because of the Sinemet. And then it would just be recommended that you try a different formulation. I think this was important to know for patients who are in inpatient rehab and are maybe on their home schedule for their medications, but maybe not on their home schedule for how they eat their meals. So because some patients who take levodopa with a high protein meal, it can have decreased absorption in the gut because the levodopa and the protein are fighting for receptors for absorption. Also, taking levodopa with a high fat or high caloric meal in general can delay therapeutic onset. So generally, it's advised that patients are taking their medication 1 to 2 hours before a meal or with a small meal if they're having a lot of nausea, vomiting. So I know this is a chart, but I will go through it. So we have mild, moderate, and severe Parkinson's disease here at the top. If you look at the left, you can see under mild Parkinson's disease, we have that oscillatory line. That's your blood level of the levodopa. So for example, at the bottom here, the patient takes a dose, the blood level increases, it gets to its peak. At the peak, we might enter a range where we're super therapeutic and getting some dyskinesias as a side effect. And then we drop back into the therapeutic window. And then as we hit the trough, we might have some off time where the medication has worn off and the patient now has some of the features of Parkinson's coming back. And it won't be until patient takes the medication again and they re-enter that therapeutic window. The difficulty arises as the severity increases, that therapeutic window narrows, which means that spends more time in the off state or can have more dyskinesias with levodopa medication. And that's what we use a lot of adjunct medications for to help combat that. So your on-state levodopa-induced dyskinesias, they tend to be choreiform movements, these dance-like movements of the extremities, and it can be bothersome to patients. How do we target increasing the on time, decreasing the off time, and decreasing dyskinesias? So for management of dyskinesias, the most common medication we use is still amantadine. One thing about the amantadine is that it can increase some of the cognitive symptoms of Parkinson's, unfortunately. But with the reduction in dyskinesias. So if you see amantadine on there, it might be to help the patient with these. Other adjuncts, these can help decrease the off time and increase your on state during the day. Those are your COMT inhibitors, MOAB inhibitors, and dopamine agonists. And then for severe periods of off state where patients are getting severe Parkinson's symptoms, there's these rescue medications that are now available. So the inhaled form is Inbrija. And I have had one patient at Sheltering Arms that I was doing a check-in with a continuity of care note who told me that they did have an Inbrija inhaler. These are the adjunct medications. There's a big list of them. I think it's just useful to recognize some of the names as we're doing our medrecs for Parkinson's patients on inpatient rehab. These are some of the newer medications that are out, and these medications aim to decrease the side effects that are seen with some of these while maximizing the benefits they have for patients. I think it's useful just to know a little bit about some of these surgical devices. So the deep brain stimulator, or DBS, the neurosurgeon places leads in the brain, either unilateral or bilateral, in the substantia nigra or globus pallidus. And the lead is connected to an implanted device that sits in the chest, kind of like a pacemaker. And you can interrogate this similar to the way that we interrogate like a baclofen pump. Patients are awake in the operating room when this occurs, so the neurosurgeon is placing the leads, and the neurologist is in the room doing the Parkinson's physical exam as the leads are getting calibrated, and it's very cool to watch. I got to see this at Wake Forest. And then only certain patients are good candidates for this kind of procedure. So patients that are having like a more narrow therapeutic window, getting a lot of levodopa-induced dyskinesias, these patients have to show a clear response to levodopa, and they have to have true Parkinson's, not a Parkinsonian syndrome, and then they have to be medically stable to undergo a procedure. MRI-focused ultrasound we did not have at Wake Forest, but similarly can be used for both Parkinson's and essential tremor. And it's considered a non-invasive procedure, and the ablation seems a little bit more permanent, whereas the benefit of DBS is that you can continue to recalibrate the lead to reduce side effects and maximize benefit of the patient as the disease is continuing to progress and motor symptoms are getting worse. Duopa is that levodopa-carbidopa intestinal infusion, where the medication is getting pumped directly into the stomach from an outside port. There's also subcutaneous injections. The Vyalev is the newest one that was approved just last October. And now we get to rehabilitation treatment for Parkinson's. So the first one for kind of PT-related therapies is amplitude training. So patients with Parkinson's, they have these micro movements, and some of this has to do with the patient's own perception of their movements. So when they're making these micro movements to them, they're perceiving it potentially as normal, and we have to give them these cues to remind them to make these larger movements and retrain that perception. So they're encouraged to make these exaggerated movements with the use of visual and auditory cues. And they try to make the movements functional so that they mimic things like walking, reaching, bending down. So there's this is a very particular kind of amplitude training. It's called the Lee Silverman Voice Treatment Big. So Lee Silverman Voice Treatment Loud is a speech therapy program that we'll talk about later. They had a lot of success, and so they created this big therapy for amplitude training as well. And this was a meta-analysis that looked at a couple different studies that included this LSVT big training, three of which were randomized controlled trials, and they compared the therapy to other kinds of standard PT and exercise therapy. And they found a significant improvement with the amplitude training in UPDRS motor score. Reciprocal training, that's where we're trying to do reciprocal movements with our arms for good arm swing, reciprocal movements with our stride length. And a lot of this sounded like it mimicked aerobic exercise therapy. And I did find research talking about aerobic exercise therapy. A lot of this has to do with things like walking exercises, rowing, elliptical, stationary bike. So in this review, they talked about high or moderate intensity aerobic training. They found that it was safe for patients with Parkinson's, and it was likely beneficial for motor symptoms and overall function. A lot of these studies kind of have poor quality evidence, and so they can't make definitive statements, but the trend is that they're having some benefits. And they also recommended that patients should be engaged in these kinds of exercises early, and that they need to continuously engage in these exercises long terms in order to sustain the benefits because retention is poor. Resistance or strength training. Similar review, they looked at higher moderate intensity resistance training. They found was safe for Parkinson's patients. It increased specifically muscle force production and can reduce that UPDRS motor score. And they found that patients benefited more when they were doing strengthening exercises targeted to things that they found difficult. So, for example, patients who are having difficulty with stand pivot transfers, or patients who specifically have difficulty with their cough. Balance therapy. So in this review, they found that balance therapy was effective in reducing fall rates, but only in mild to moderate PD. There is some thought that for patients with severe PD, sometimes exercise can make them feel a little overconfident to the point where they're trying to get up and moving without the proper safety protocols, and it can actually result in increase in falls for patients with severe PD. And they found that clinic-based programs had a greater reduction in fall than our home-based programs. Gait training for freezing gait. So similar to amplitude training, using visual cues, auditory cues. For example, like here in the left, you can see the patient walking on the treadmill, trying to aim for the dots to increase her stride length. And then in the right here, you can see the patient is walking to a metronome, and the metronome is letting them know what rhythm to take these steps at. And then gait training for freezing gait, we have these strategies. So some overlap with amplitude training and trying to take large steps. Some overlap with reciprocal training and that we're working on good arm swing. Also working on good weight shifting, shifting weight from one leg to the other leg. And then practicing turning maneuvers because a lot of freezing can occur when the patient's trying to turn. So there was a meta-analysis, looked at 36 different studies, 12 different types of exercise for freezing of gait. And they found that in general, all these kinds of training modalities, obstacle training, gait training on a treadmill, general exercise, regular physiotherapy, there were like immediate real life benefits in specifically patients with mild and moderate Parkinson's disease. But then if you look at this review, they had more long-term follow-up, and they found that there was poor retention of these effects after they stopped doing the training, which again suggests that they need to continue to implement these kinds of training in a long-term management plan. Dual task training is another common one for Parkinson's. Like you can see, these patients are both performing a motor task by walking on the treadmill and then also trying to perform a cognitive task. And so in this review, meta-analysis, they looked at 14 different randomized controlled trials comparing dual task versus single task gait training, with their outcomes looking at factors in gait like speed, stride length, and cadence. And they found that single gait training, as we would expect, also helps improve gait parameters. And there was only a modest benefit in doing the dual task gait training over the single task training, without a significant change in the UPDRS motor scores. And in general, like lots of these studies, in general, there's a low level of evidence, high risk of bias, and poor long-term follow-up. Dance therapy for Parkinson's disease. As you can see in the left photo there, looks like they're also incorporating some form of amplitude training, trying to maximize those big movements. This was a systematic review and meta-analysis. They reviewed several different studies, but they could only include 2 of the randomized controlled trials in their meta-analysis due to heterogeneity of the studies. And they found that dance significantly improved balance specifically and timed up and go. And that specifically, it was the tango form of dance that was more beneficial than other dance forms. In general, there was no significant effect on the motor scores, the freezing of gait scores, or the PHQ-9 scores. Aquatherapy. This was a systematic review. It looked at 6 different randomized controlled trials. They found that aquatic therapy had similar effects on motor impairments in general and functional mobility. Aquatic exercise did improve significantly, specifically balance scoring and reducing fear of falling. Stretching therapy and yoga therapy, and then some of our complementary types of exercise like Tai Chi. In this review, there was no definitive benefit in doing these kinds of complementary therapies over standard exercise therapy. Boxing, so the Rock Steady boxing classes is kind of the famous one. In this meta-analysis, they found that boxing training for Parkinson's disease did not demonstrate substantial impact in physical or mental health outcomes. And then we have speech therapy. So as I alluded to earlier, the Lee Silverman Voice Treatment, or LSVT Loud program. So this is a review that looked at LSVT loud compared to respiratory therapy and no training. They looked at 10 different randomized controlled trials. They did find a significant improvement in vocal loudness and speech intelligibility, specifically only in mild to moderate Parkinson's disease. Music therapy. Thank you for Dr. Haywood at the Pain Clinic for providing me with some resources about this. I also found this review for music therapy specifically for Parkinson's disease. Looked at 58 different studies. They did find improvements in motor scoring, communication, and some neuropsychiatric outcomes, so specifically mood, with less of an effect on cognitive abilities. And then lastly, we have some devices for Parkinson's disease tremor. We have these wearable devices that can help with the rest tremor, which can be bothersome or even embarrassing for some patients. And then also patients that end up developing an action tremor associated with this, more of like an essential type tremor. There's also wearables that can help with patients being able to use certain utensils and devices like computers, pens, iPads. Conclusions for my review of rehabilitation treatment for Parkinson's. In general, we need higher quality randomized controlled trials, which show evidence of an improvement for patients in order to make more definitive recommendations for whether or not patients should be enrolled in these rehab therapies. It does seem that exercise in general seems to be beneficial for patients in terms of their motor function. Especially and specifically the mild to moderate category of Parkinson's disease. A lot of the researchers in the literature that I reviewed recommended that we fit the exercise regimens to the patient in terms of what they're needing. So, for example, a patient who is having a lot of concerns about falling, fear of falling, might benefit more from specifically continuous engagement in balance therapy. And then all of these studies suggested consistent long-term engagement would be required to sustain the benefits of therapies. It seemed that there was a trend that there was poor retention of these skills. And then in general, it seems like even though our PHQ-9 scores didn't necessarily increase or quality of life scores didn't necessarily improve in the analysis, it seems like involvement in therapy does encourage community engagement and does increase the socialization of the patient, where else otherwise they might be at home not socializing. And so for that reason, I think it is still important to continue to encourage the patient to pursue these kinds of group exercise classes. And then I think it's the Academy of Neurology, the American Academy of Neurology is recommending that movement disorder specialists at least have a conversation about exercise therapy and rehab therapy in Parkinson's disease patients annually to make sure that they are including rehab therapies in the multidisciplinary approach for Parkinson's patients. And then I have my works cited and questions, and that's my husband and my cat.
Eva, this is Dr. Q. Can you hear me?
Yes, I can.
I'm sorry, I'm driving, so I cannot show my face. But anyway, wonderful presentation for you, very concise and to the point. I have a couple of things that discussion is that we talk about the pill rolling movement. We talk about the tremor, the way it is. The MDS, the Movement Disorder Society. They don't say anything about nowadays about pill rolling movement. I have been doing this over 25 years. I think I have only 3 patients that I actually saw their pill rolling. So the tremor is actually a resting tremor that they said, and very, very rarely you will see that pill rolling. And the other thing they also mentioned about the rigidity. We have different types of rigidity, cogwheel, and all these things. The cogwheel is basically in the old books, it always says the cogwheeling. But MDS, movement disorder, they said, well, rigidity is rigidity. They are not, dividing it to cogwheel or leg fiber rigidity. But it is better to know there are different types of rigidity. And this is a fantastic overview of Parkinson with rehab. I really appreciate, and I think all of our PM&R residents, they will get more information in our chapter, Dr. Tipu's rehabilitation book. And this time, the new chapter is coming with a little bit more information, and I will definitely ask you all to read that before you go to our, the clinic. So it will give you a little bit more broad aspect of movement disorders because we don't see too many patients with Parkinson plus syndrome. very rarely, but if you read and if you see one, you will never forget. Thank you again.
Thank you, Dr. Q, for those comments and for the additional insight there.
I don't know if you're seeing the chat, but just want to read off Dr. Caruso's comment. She said, just a word on Vyalev, the new subcutaneous formulation is rather exciting for the Parkinson's community since it bypasses first pass metabolism. In theory, there will be less off times. It's very expensive with costs ranging from over $2,000 a day. Currently in review for prescribing information at the VA.
Awesome. Thank you for that insight, Dr. Crusoe.
Eva, this is Dr. Hoopy. I had a few applicants actually during when I was reviewing their applications that did volunteered with Parkinson's programs for HIT training, where they did high intensity interval training. Did you see any evidence specific to that type of exercise in Parkinson's?
I did not, and I think it's mostly because like the research is lacking. I also tried to look at like virtual reality and a few other kinds of training, and I just couldn't find enough good research on it. But I imagine that the HIT training kind of combines a little bit of the aerobic exercise with some of the amplitude training. There seems to be a lot of overlap with some of these other kinds of exercises.
So I think bottom line, just try to get your patient moving and doing something they enjoy will be beneficial. Is that kind of a big takeaway of that?
Yeah, that's the thought. I think that the evidence will continue to get better. I think in the last 10 years, the quality of the evidence is improved, is what I've just been reading from my literature review. And as we're doing more research into it, we can see what's safe for Parkinson's and for what kind of subtypes of Parkinson's. It might be that HIT might be a little too much for Parkinson's patients. And then also narrowing down like what's the most important for the patient. Is it amplitude training or is it aerobic training in general? And then, like I said, it seems to be very patient specific. So patients that are specifically having more issues with amplitude, having these micro movements, or patients that are having more freezing of gait issues might benefit from like very specific tailored exercise regimens for those patients.
Awesome. Thanks, Eva. It was a fabulous talk.
Thank you, guys. Any other questions in the chat?
Nope.
All right. Thank you, guys. Have a good rest of your day.
Thank you so much.